Hi all. We'll just let everyone else in. Hi, I'm Alison. I'm from Effective Policy. Usually Gina does these, but she's lost her voice today, so I'll be talking today. And we're going over the assist with medication common non-conformities for NDIS providers. I'm just going to let you know in advance, my camera has been playing up. So if it cuts out halfway through, I'll just have to turn my camera off and keep going. But hopefully it doesn't do that today. Um, so guess we'll get started because it's 5 past now, so everyone should be here now. So if it works for me. So today's session is going to cover our most common non-conformities. So we'll go over the quality standards first, and then we'll explain our three most common non-conformities, and then cover any other areas of concern that we often see. We'll be giving practical insights on how to address and prevent these issues. And we'll also be doing a Q&A just to answer any specific questions you've got. So to start with, in the medication management standards for the NDIS, the outcome is that each participant requiring medication is confident their provider administers, stores, monitors the effects of their medication and works to prevent errors or incidents. So there's 3 indicators within this standard. That records clearly identify the medication and dosage required by each participant, including all information required to correctly identify the participant and to safely administer the medication. That all workers responsible for administering the medication understand the effects and side effects of the medication and all the steps to take in the event of an incident involving the medication. And then also that all medications are stored safely and securely and can be easily identified and differentiated and are only accessible by appropriately trained workers. So um, there's only 3 medication standards for the NDIS, probably not enough in most consultants and providers' opinions, but this is the standards we've been given. So these are the ones we've got to align to. So we'll start off with our most common non-conformity and the one that when we do internal auditing, we see as a very, very common problem is that assessing a person's medication capacity and understanding when you're actually assisting with medication or doing medication management. So medication management includes 3 things. It includes prompting, assisting, or administering. So the very important one that everyone seems to forget is that if you remind someone regularly or even remind them at all to take their medication, you are prompting and therefore you are doing medication management. So if you have a participant that each day you say at 10 o'clock it's time to take your medication, then you need to have all of these things in place, all those standards that we just spoke about, all of them need to be in place too. So you'll need all the paperwork, you need all the training, you need to be, if it's a supported independent living home, you need to be storing it correctly. I just saw a question in the chat, sorry. Oh, um, it's not letting me check the chat on my thing. Oh, there we go. Sorry. Will the slides be available after this? We don't usually give the slides, but the recording will be available after this. So you'll be able to watch this again for 30 days afterwards. So yes, Gina's just pointed out the moment you assist in any way, shape, or form with medications, you're assisting with medication. So quite often what we find is that you as the organization's director or CEO may think, no, we're not doing any of this. We don't deal with medications. We don't want to get all the paperwork done, so we don't do it. We ask the participants then during an internal audit, do they assist with your medication? Do they remind you to take it? And they say, yeah, the support worker every day tells me to take my medication. We ask the support worker and they say, yeah, I just figured I should. And then we come back to the provider and let them know that actually you are doing medication management and it's a major non-conformity now because you haven't got any of that paperwork in place. You've done nothing for it, but your staff are taking on this responsibility that they're not meant to be doing. So you need to make it very clear to your staff and to your participants. that if you are reminding them for medication, to take medication, then you need to be doing these medication standards and everything needs to be in place. So that's a decision you'll have to make whether or not you continue to remind them and get all this paperwork in place, or you say, I'm sorry, we can't remind you because then we're doing this medication management standard that we're not meant to be doing. If you're not registered for it, you definitely shouldn't be doing it. And if you are registered for it, then you just need to get all that paperwork in place. So our next common non-conformity is that paperwork isn't clear. So when you're doing medication management, you'll need to have the following documented. You need consent for you to be managing medication. You'll need the name of the medication, the dosage, the frequency, the route, so how they're actually taking it, the reason for taking that medication, and any potential side effects and effects of the medication. You also need your role listed, so whether or not you are going to be prompting, which means reminding them, assisting, so just handing them the medication, or actually administering it yourself. And you'll need any review dates that are required for those medications. And all that information should be given to you by a GP. So you need to make an appointment with the GP for the participant and make sure they fill out the forms correctly. In a moment, I'll show you some forms that just to show you sort of what we'll be looking for. Another problem with paperwork we often see is not giving clear handover notes to the next staff member. So if, for example, you've got someone starting a shift at 9 o'clock, and medication was meant to be taken at 9, sometimes the person before doesn't actually give it to them. They don't write it in the notes that we missed the medication, and then it ends up that the person misses their medication and it's a whole big problem. Medication error. So you need to make sure as well with paperwork that when you're recording down if a medication is done, that it's very clear. Sorry, I'm just reading the chat. It's incredibly important too in some situations to do a medication capacity assessment, i.e. is the competent person, how competent is the person to take their own medication or to not take their own. So yeah, we'll show a competency assessment as well. Yes, Gina, I'll share the competency assessment. Just give me 1 second. Bear with me while I get that medication competency assessment up to check if a participant is competent to take their own medication. So medication risk assessment or risk identification. So it's documenting the patient's level of independence and their ability to self-administer medications. Is everyone able to see my screen? Just check. If you could just give me a thumbs up if you're able to see it. Yes. Okay, great. So if you can't see my screen, you might need to just click around on Zoom to make sure you can see it. Okay, thank you, everyone. So your medication risk assessment goes over the risk identification, so your level of independence as well. So you're checking whether or not they live alone or they live in residential care, uses dosage administration device. So just checking those things, and the client assessment, whether or not they can read and comprehend labels, whether or not they can open bottles and tubes, checking those as well as a medication history checklist, and then recommending a medication review if they need one. This is just sort of to give you an idea of whether or not you should be just assisting or reminding for medication, or whether or not you should be administering the medication yourself. It depends on the participant's capacity to do that. And so that is what that form is for. I'll just pause my screen and go back to our PowerPoint. Just bear with me for 1 second. So the other thing that in terms of paperwork is that records must be kept of the medication management. So medication logs must also be kept. You need to be keeping notes, noting down the date, the time, the source, the medication, the type, and if it's a PRN medication, any observation, if it's a PRN medication, you need to be noting that down as well, and any observations you see. So knowing what effects and side effects to be looking out for, and a signature from the staff to let them know that it was seen. And if you are doing PRN medication for a participant, you need a clarification of purpose form, which will cover what the maximum dosage is, when the PRN medication should be used, and why it should be used. And we also that should be done for PRN. So staff know why they need to give that medication out. We often find that with PRN medication, it's either over given, so staff don't realize what they need it for, and they'll just give it whenever, or they'll avoid it completely, not realizing that it's an option. They don't know when they should be using it, so they just don't. So making sure you've got those clarification of purpose forms for that PRN medication, and it is a major non-conformity to not have a clarification of purpose form for your PRN medication. So just pause my screen again and we'll first pull up the plan and consent form so you can see what that should look like. Okay. Do we have any guidelines for Schedule 8 medication in the community? Do we have any in our policy? Yes, we do. Yes, we do have that in our effective policy one. We won't be going through that just this second in this webinar, but it is included in the effective policy. Okay, so back to medication plan and consent form. So this is just getting the participant's name, date of birth, and giving consent for the staff to assist with medication management. Using with effective policy forms and templates, we also get that consent on, we just have one master consent form where we try and gather every consent possible so that way you don't miss it. But if you're not getting that, if you have it somewhere else or you've gotten to get the consent, if it's changed and you need it, you can get consent through just a medication consent form and plan. And so this plan as well is just name of type of medication, any details, whether or not they're prompting, assisting, or administering it, and yeah, getting that consent. So that's really important as well. Our next form, yes. Is a GP medication authority form enough for the PRN form? If it looks just, sorry. Okay, so yeah, if the medication consent form, if you're, what is the word I'm looking for? Medication authority form captures everything you need for a PRN clarification of purpose form, then yes, that is enough. But if it doesn't, then you'd need to add that additional paperwork. So yeah, some GPs just give a list of medication, which isn't enough. So I'll open up now our participant medication authority form so we can go through that and show. So medication authority form. So this has got the name of the medication, the dosage, frequency, timing, as well as if it's PRN or not, the route which take it, the reason, and then any start and end dates, or if it's an ongoing medication. And then further down, it's got any side effects to be aware of or storage instructions. So any information about that. Authorization, total number of medications listed, name and position of the health practitioner, and the signature, and then we've just got more space if there's more medications. So I will now just pause my screen and get a PRN clarification of purpose protocol up so we can just have a look at what's needed for a PRN protocol. So contact details of the prescriber. So if all this is captured on your other form, that's all right. The dosage to be given and the maximum daily dosage of the drug, dosage instructions, the reason that it's been prescribed, and the desired outcome. So you need to have all of that listed. If the GP has given that to you already, then that is your clarification of purpose for that PRN. If you don't have that, then you do need to have a form that says exactly what is needed for that PRN. Okay. Now we'll go back to our, so that was our participant medication authority form and a PRN clarification of purpose forms. Just so the clarification of purpose seeks to protect participants from the overuse of drugs. Yes. So either overuse, and also if it's not clear why they use it, if people just avoid using it in general and it's something that's needed, that's another problem too. So now I'll just go to our record chart. So this is an example of a medication record chart. So it's for one specific person, this one. Date of birth, the lists of medication is attached with consent. We've just got some codes here, and then a big table where you've logged down each time, date and time of the medication, the source, where it came from, type. So if it's prompt administration or did not observe. So if the client already took it and you didn't see, you note that down as well. Whether or not you performed the 8 rights of medication, right person, right medication, right dosage, route, time, record keeping, reason, and response. So if they've gone through and checked that all of those are correct, then they just tick yes. Whether or not it's scheduled or PRN, any client observations. This is a really important one that people don't often do, making sure you're noting down what effects you're seeing with that medication, because if you don't know the effects that you're looking for, then you don't know if it's working, and they don't know when they go for a medication review. The GP might go, well, is it working? Is it not? We don't know. We just give it to them and we walk away. So you need to be making sure that your staff are writing down any observations they see, and then their staff name and the signature. So just back on PRN, we have had issues with PRN clarification of purpose. There was one instance where at a day centre, there was a person working and they had a diploma in community services. They did get that from an institute that recognised prior learning, which in itself can often be an issue in this sector where people have used recognition of prior learning, and it means that they either haven't done the course or there's loopholes, things like that. So their qualification isn't as legitimate as it may seem. But in this day centre, there was a participant who was having a behaviour of concern, and the worker went into their bag and grabbed out their EpiPen and gave it to them for a behaviour of concern because they didn't know what to do. They didn't understand medication management at all. They didn't think. The first thing that was concerning to us when we heard that was, why at a day centre did the participant have their EpiPen in their bag? It should have been handed to the staff when they got there. But amazingly, it happened. It happens more often than you'd think that people are just giving medications. I've heard instances where someone has an anaphylactic shock, or an epilepsy seizure, and someone gave an EpiPen as well. It happens. People don't know what to do, and they panic, and they just do anything. So making sure that you've got these protocols in place and your staff know all of these documentation is key to preventing those incidents in the first place. So go back now to our slide. Sorry, just bear with me. When you've got 2 screens, it often overshadows the Zoom. So I just have to go back to that. So back here, paperwork isn't clear. Okay, so our third common non-conformity is that training isn't done. So training is imperative to making sure that medication management runs smoothly. If your staff don't have training, what are they doing? Um, they don't need to, yes, Gina said they don't need to know what every drug on earth does, but they do need to know the side effects for the people that they're caring for. And even if they don't remember that off the top of their head, there should be paperwork there that says what those side effects are. So it should be written down somewhere for them to easily find, even if they can't remember it every time. They should be checking and reading that paperwork. So back to this one for training isn't done. So, staff must be trained in medication management, and they also should have their competency assessed to make sure that they've got the correct skills. I'll show you in a second what a competency assessment looks like for medication management. They should be having that competency assessed to check their skills. Um, they should understand the side effects, the incident management process, and the documentation required for medication management. So in terms of incident management process, they should understand what to do if there's a medication error. They should understand who to talk to. Each organization will have their own procedure, um, which people should be inducted in when they would start working. But usually it'll be that you need to submit an incident report. It could be called a medication error form. Your organization, it'll depend. They need to be submitting that to a supervisor and letting them know that something's happened. If it's obviously a more severe incident, um, if they're having an allergic reaction and an anaphylactic reaction, then obviously, it needs to be escalated quickly, call an ambulance. But for other medication errors, it needs to be recorded, and that information needs to be analyzed by the staff, not the staff, the management team. So we've looked in organizations where I've had a review of their incidents and they've got 17 open medication issue errors from that month. And you look at that and you go, okay, obviously something's wrong here. What's wrong? It's that the staff don't know what they're meant to be doing. So therefore you need to train them. You need to be looking at these errors and those incidents. Um, sorry, regarding competency, the person facilitating the competency of the staff member, what level of training do they need to have? Is it enough that they are the manager of the service? Um, Gina, if you could just pop in the chat what the guidelines are for that. Um, and then we can go back over that. Sorry. I'll get Gina to answer that one via the chat and I will start pulling up the competency assessment. I'll just give Gina a second to type in the chat and then we can go over that and we can look at the administration of medication competency.
I think I'll just try and talk actually, otherwise it's going to be like War and Peace. So, okay, it's a really good question. So back in the old days, and what I say that is before the NDIS, anyone who worked with medications had to have the competency from an RTO. And it's just not possible today. And the reason being is that we had 200 providers in every state before the NDIS came out. Now we have 215,000 providers. It's not possible. So as a informal, unspoken kind of law, we all just think, well, let's just do everything we can to protect these people as much as we can. So the ideal would be that a person in your organization has a medication competency, at TAFE or RTO. Now, we're still not even going to give you a major nonconformity if you don't, because half or 3/4 of the providers today will be out of action if we went through with that. Okay. So that would be ideal. And I always suggest to everybody, someone get the competency and then that person can do the competency check. Does it have to be a nurse? No, it does not. It does not have to be an RN. It does not have to be an EN or an EEN. It can be a person who is completely competent at medications because it's designed at a certificate 3 level. Yeah. Now, ideal would be to have someone in your organization always who can check competencies. When someone has not delivered a service for at least 3 months, they should have their competency checked again. It just makes perfect sense. They should also, this is just best practice, it's not a legal thing, you should make people do their competencies annually anyway, okay? So it's a competency checklist aligned to the RTO's framework. A worst case scenario is that you've got no one in your organization that has that competency. Then I would start taking steps to get the most practical person to do it. The person who isn't going to walk away in a hurry, the person who is going to be around, knows what they're doing, then, you know, they've got a few brains in their head and they can do the competency checklist once they've done the competency at with an RTO. That would be my advice to you. Worst case scenario, at least somebody has to be checking that competency for people once they've done some training. There is no way in this world that people could be sending every support worker they have to do a $600 RTO competency, or best case scenario, they'll charge you $2,000 for a day to come out and do a group of people. It isn't possible. It's just not economical. So that is the best way to do it. Okay. There's best and then there's, you know, average. So I think I've pretty much covered that. Thanks, Ali.
Great. So our competency checklist, it's just ticking off whether or not staff reminds person it's time to take medication, identifies the level of physical assistance required. So whether you're just checking that competency for them. And like Gina said, it should be done, it ideally should be done annually, and we do have a template for a reassessment after a year. Yeah, just going through and making sure staff not only are trained in assisting with medication, but also getting that competency done is a big issue that we see.
Yeah, I think that having the training and not the competency, really, you've gone only halfway, if that.
Yes.
So,
And
yeah.
I'll just also pull up our other document. Just bear with me. There we go. So we've also got a competency assessment for PRN medication specifically, because again, people need to understand the difference between medication and PRN and scheduled, understanding why it's prescribed, can identify the participant. So going through and checking this competency as well. It isn't in the standards explicitly that they need to do it, but they do need to be competent in it. So this is the most obvious way to do it.
I mean, it's bizarre that they're not in a standard. It's absolutely bizarre. And we've
Yes.
seen all the new psychotropic standards that have come out in an Australian set of standards that NDIS and aged care have participated in. I expect that we can see some standard changes coming up based on that, because they certainly haven't done a particularly good job of rolling out those Australian quality framework standards to anybody. So I think it's just ludicrous that the most unskilled group of people in a health setting are given free rein on a whole lot of PRN, Schedule 8, or, you know, quite dangerous medication. It's just like a perfect storm.
Mm. Mm. So that is our 3 most common non-conformities. And then I'll just go through and we'll talk about some of the other ones. So another common non-conformity, so relating to the first indicator about that records clearly identify the medication and can correctly identify the participant, is that you can't identify the participant's medication file. So this is particularly happening in SIL homes. I've seen some cases where they'll have a binder with a bunch, or they'll just have a bunch of loose medication documents just scattered throughout. They don't have a system in place. So that is it's a common one. It's not the most common one we see, but if you're in a SIL home with multiple participants in there, there should be a binder that has one person's medication information in one and another binder with other people's. Ideally, there should be a photo on the front so you can very clearly identify who the participant, who the medication folder relates to, and it can be identified. So that's another common one. Um, Indicator two, so we listed two more from here that um, with all workers responsible for administering medication, understand effects and side effects, and that they can take steps. So again, no side effects listed. It is a very, very common thing. People will have almost all the paperwork in place, but when I ask them what the side effects are of the medication, they'll look at me blankly. Um, you can you can find online anywhere a bunch of fact sheets as well about medications, and you print those off, keep them with like a detailed list, but the GP should be telling you and it should be documented on that plan. But you can take extra steps as well to get those side effects listed. And the staff should be aware of them. It should be in that medication folder that they can see easily. Main reason is if they don't know what the effect is, they don't know if it's working, and they also don't know if something's not working or if it's having an adverse effect. Um, if they don't realize that a rash is a sign of a severe reaction to a medication, they might just think, oh, people sometimes get rashes, that's fine. Um, so making sure that those side effects and effects are listed very clearly and that the staff are aware of them. And then also the lack of understanding on that incident process. So a lot of the time staff aren't properly trained in how to handle incidents or haven't been shown what to do in the case of a medication error. And then incidents that could all involve a medication error, it could involve severe side effects, and it can also involve refusing a participant refusing to take medication. You need to note that down. If people are refusing to take it, you need to write that down. Um, and Other common nonconformities that I see is that medications are not safely or securely stored. Some I have heard that some auditors tell people that you can't lock up medication in a SIL home because it's a restrictive practice. That is not the case. It needs to be safely secured. In a shared living environment, it should be locked in kept in a locked cupboard. Participants should be able to ask you to get their medication because if it's a 24/7 care place, there's always going to be a staff member there. You can always ask to get your medication out and someone will unlock it for them, but it shouldn't be able to just be free reign from anybody in the house. Um, so keeping those secure is the best thing. And also, we would always recommend the ideal way to get medications from the pharmacist would be in a Webster pack. Because that keeps it easily identifiable and it also prevents medication errors. It prevents you picking up the wrong bottle, wrong blister pack and giving it to someone. It prevents any of those issues. Oh, and yes, and fridges. So if medication requires being stored in a refrigerator, it is best to not put it in a communal fridge. It is best to have a little medication fridge somewhere. Um, in the staff office is usually the best place to keep it. And making sure that, yeah, it's not in a communal area because then you come back to that problem that it's not stored safely or securely. And so yeah, with Webster packs, they're the ideal way. It's not a non-conformity if you haven't gotten or if you haven't organized a Webster pack, but it is the most effective way to prevent any issues and medication errors. You can also get other things besides Webster packs. They now have sachet options. There are a lot of options, so ask your pharmacist about the best way to do it, but those systems are always going to be the ideal. And those are our most common. So if anyone has any questions, please either write them in the chat now or you can unmute yourself and ask.
Hi, I have a question.
Yeah. Go ahead.
Um, Thank you very much for all this wonderful information. It's quite a lot, but quite useful. Very simple delivery. I really appreciate it. So I have a participant who had a brain injury, and he's very like man with a who likes to have a control of his own life. So his range of understanding is very limited of the outside world, and his memory is not very great. So occasionally we do remind him about the medication, but he always screams back, "I'm not a baby, I'm not a baby." Um, so he does sometimes forget, but he usually pretty much, is okay with taking medication. But he wants to keep them in the place where he wants to keep them, usually under the pillow somewhere in his room. He doesn't want to sign any paperwork, so he doesn't let anyone to interfere with his medication. So he listens only to his GP, and he does, he just marches under the music or drumming, whatever the saying is. So he does whatever he wants to do. So what do we as a staff and
So
um
tell me, is he
yep.
in a SIL home?
So he's not in a SIL home, but we're trying to get him in a SIL home because
Okay.
yeah, there was a big issue with his accommodation, but we're really very concerned about yeah, what's going to happen with his medication. Like
Yeah,
even with the staff is going with all the best intentions, want to help and want to keep all the paperwork in check,
yeah.
but he's just not cooper. He just doesn't let anyone to do
Of
any
course, of course.
business.
And
So
so, I mean, there's a whole lot of lack of empowerment and a whole lot of other stuff going on there. And if he goes into a shared home, there's not
mhm,
going to be a lot of choice because this the safety of other people will come into that. Now,
mhm,
sometimes it's like when we push somebody to do something, that's where we might see the cracks or the chinks. And
mhm,
so that's what's happening here. So the best thing that you could do is to probably try to get some positive behavior support um, assistance to see if it can be managed sooner rather than later to see what someone can come up with in terms of working around some
mhm.
of those hurdles that you're experiencing, which are partly due to brain damage and partly due to the fact that he's feeling quite disempowered. So and it's not a simple thing to manage, but one that's far better managed with advice from um, someone with some skill who could possibly put together some strategies for you guys.
Yeah, we had a, different positive behavior practitioners, and like the best thing that ever happened, like it's just we just let it to his own, like you just let him to do that. He obviously does feel disempowered because he doesn't understand a lot of things, and
Yeah,
he, like first of all, English is not he this is Australia is not his home country. English is not his first language. So there is a lot of kind of,
there's a
as
lot
you
going
said,
on.
yeah, as you said, a lot of defensiveness and a lot of disempowerment. So he wants to be in control of his own life, and the
And that's fine. Choice and
well,
control is
yeah,
fantastic, but it is never going to be at the expense of duty of care.
yeah. So how do you, like, if he
It's a
doesn't
behavior
like
issue.
if it doesn't work,
It's a
because
behavior issue.
mhm,
The answer is not in the medication standards. The answer is only in a good behavioral strategy.
and if everything
First,
fails,
pardon?
if that fails, like if no behavior therapist can find any, like we already had three, and
There are some pretty bad behaviour support practitioners out there. The Commission are completely and utterly aware of that. Um, a majority of them, I think they're saying 30 to 40%, are so inexperienced they don't know what they're doing.
mm-hmm,
So they've sort of changed structures around that. So I think getting someone who's really good,
mm-hmm,
not just someone who's been given practitioner status as, you know, a core practitioner, going to someone who really has, you know, that top layer, that top tier of practitioner skill, is probably more, you know, in keeping with being able to have a success. At the same time, of course, we know from experience that working with people is sometimes not always easy at the same time, but you won't know until you tried the best.
Right.
Because I don't know whether you've
yeah.
tried the worst. You know, I
Yeah.
just don't know.
Yeah.
So yeah, it is a behavioural thing. But risk assess, risk assess, risk assess. And until such time as you can find someone to step in and give you, you know, perhaps one more bit of advice, but make sure that they're a specialist. Make sure they're a specialist level or advanced, not core. Every time you guys get a behaviour support practitioner, that's what level they are. Because there are some really bad ones out there.
What did you say? Can I ask you a specialist level or master
Specialist
level?
or advanced.
Advanced, yeah.
Yeah.
Okay.
Apart from anyone that's just provisional, stay away from them. But you know, and I say that because unfortunately they just have very poor skills. You don't know who's supervising them. So I would say, you know, you need to tackle it from that perspective, but risk assess, strategy all the way through until you can get somewhere.
Yeah, look, I appreciate what you say, but in terms of where does it leave the provider, like if, like, you know, because
Well, it
we
kind
put
of
in
leaves you,
so much
in a bad
responsibility.
place.
Yeah, exactly. So
It
it
does.
puts all the responsibility on the behavior support practitioners, but if that kind of doesn't work, so like what does the provider how the provider can you know, protect themselves or explain or give some sort of explanation or cases, or does the, you know,
There's
how
got
do
to be
you
some strategies that can be put in place that keep everybody safe there. You know, it's obviously a much bigger question than can be answered here, but there's got to be some strategies. I do not, I won't support that there are no strategies that can go towards making this a better situation. It's about who's on board helping you with that.
Thank you.
Yeah.
Appreciate that. Thank you very much.
No problem. I'll just check. So the chat, we've got a few questions here. So, and I can see, Alicia, you've got your hand up. I'll just read the chat questions first and then I'll jump to you. So, Rachel, for our day service, do we staff need to hold all medications or can it remain with the participant? For most of them, it is PRN. And if we hold on to it and go out into the community to do an activity, should we take it in a bag with a lock? If you're going out to do activities, I believe that it can stay on the participant, but if they're going to be just at the service, the day center all day, they should be giving it to you and then you should be giving it back to them. So you need to have a protocol in place to make sure that you're giving it back to them at the end as well.
Correct.
Yeah. And so Ruth said, if another service is also providing the support to a participant, would each service have to have their own records for medication, or would both services use the one record so they can see if a medication dose has been missed from the previous shift? So you both need to have, everybody needs to have records. So in terms of making sure, you just need to make sure that there's with the agreement with it doesn't like say necessarily in the standards how you'd have to do that, but you'd have to have an
That's the
agreement.
key word, the
Yes,
agreement.
you'd
The
have to have an
agreement.
agreement in place
Yeah.
with them to make sure you're both understanding what's expected of you, whose role it is to do X, Y, Z, whether or not
Absolutely.
it's always the person who has the first shift, whether or not it's always one particular service who does
Yeah.
it. You need to have that in writing, make
Yeah.
an agreement, and then figure out
Stick
how
to
you're
it.
going to share those medication records because it's not prescribed in the standards. There's no way you have to do it, but it does have to be done, and an agreement is the obvious way.
Yeah.
And then, sorry, on the same note of two services working with the same participant, would a missed medication assistance from the other service be a notifiable incident?
Well,
So
it's a
it,
it's it's a reportable incident, but yeah, it is.
Yeah. Okay, and then there's one more question. Is it enough to train all staff in knowing how to access the CMI for the medication and how to read it regarding knowing side effects? So
No, I think you
client,
should be doing a course, even if it's non-accredited, like many of us out there offer. I think you should be letting them do a course that's at least based on an accredited model.
yeah. Okay, and Alicia, you had your hand up, so
Hello, thank you very much for this training. I did have a question and you may not be able to answer it, but I thought I might as well ask. I have a participant who is seeking my support services. They do have chemical restrictions in place as part of their medications. However, I'm not currently registered, so I am in the process of trying to get registered, but it's very, very long process.
yes.
She has said to me that there is other providers, and I do know of another provider out there who is also in the process of registering, but they are able to provide administer the medications that are chemical restrictions to the participant that they're supporting. I'm wondering if you know, is there a way that someone who isn't registered can provide their support services to a participant with chemical restrictions
At
in
the end of
place?
the day, you're not supposed to.
Yeah.
The thing that you could do is subcontract from another organization, but there is all sorts of issues there. Did you take the person on, or did you inherit the restriction, the restrictive practice?
I haven't taken them on. I've just said to them that I needed to explore it a little bit more and find out. I
Okay,
have
right.
explained to them that I'm in the process. It's someone who I worked with previously, quite a while ago now, but through another company I was working for. And they've kind of reached out to me, and I just said, look, I need to look
I
into
get
it
it.
more because of the chemical restrictions.
The right thing to do would be to say, I can't right now.
Yeah.
I know that's the kind of lose out, but it's the right thing to do because at this moment, you're not registered to deliver
Yeah.
restrictive practices. Now, there are lots of people out there, and it must sound really unfair. There are lots of awful providers out there who either don't care or didn't know. I don't know which one's worse, but
Yes.
the amount of people we inherit as consultants that they're seeing someone, they're unregistered and they've got a restrictive practice, it just makes me ill to think that that goes on. I mean, I can't tell you what to do. I can only say what I think is the right thing to do. And is everyone else doing it? Nah. But
Yeah.
I'm still going to give you the same answer.
Yeah, look, ideally, I want to make sure that I am doing it within the scope of the NDIS. So if that means that I have to say, look, not right now, that's okay. I just did wonder if there was.
Yeah. No, there's not really.
Yeah, that's okay. Thank you so much.
It's okay.
Any other questions? I'll just move on to
I have a last question. The participants who are in SIL, they are very much open, provided they're bounded by the scope of practice and the paperwork. I was wondering, the participants who live in ILO, in independent living arrangement, is there like the same practices apply to them with the medication, or they kind of self-administer and like
You see, that's not the question. See, medication management applies to everybody.
everyone.
So whether they're
The
ILO
same.
or SIL or community or day centre or whatever, none of that is irrelevant. The capacity of the person, that comes back to that capacity. Can they deliver it? Can they give it to themselves, or can't they? And at what level can't they?
Oh, I see.
Yes. So the storage of medication and those things, that's where the nuance of SIL comes into it. But at the end of the day, if you're reminding them at all, if you're assisting or administering at all, then it's all medication management and it all has to be done. Yes.
Yeah.
Okay.
And
You
there's
can
nothing you can do about someone if you walk out of there of an afternoon and they're in their own home and you know, they've got a ILO with mum and dad and it's back in their backyard, or you know, there's nothing you can do about if they want to leave their medication everywhere. It's like community, basically.
So it's only about storage. There's a difference, but not about the responsibility of the provider administering medication. That's
Well, if you're entering into somebody else's home, you can set it up the way that you know it needs to be set up. But what they do after you leave, there's very little you can do anything about that. Some people, you know, it's hard to imagine that ILO is going to need much medication assistance because they don't get that many hours. ILO is not SIL. ILO is differentiates itself from SIL completely. SIL needs 24/7. ILO does not.
Yeah.
So they shouldn't need a lot of medication management unless it's, you know, they shouldn't need that. It should be quite minor in its requirement, you know.
So, and if you as a provider or as a support worker assisting somebody who has ILO, but you don't remind him about the medication, like you don't check if they took medication, you don't help, so that basically becomes not your responsibility. Is that right?
If they don't require you to check that they've taken their medication, then you don't check. If they require you because it's part of their need, that's different. But it wouldn't be ILO because medication is taken on a daily basis. And ILO is not daily support.
Oh, I see.
Or if there's a different package of care. ILO is not 24/7.
Yeah.
You know, maybe there's 2 hours, but you can't guarantee someone's going to come at 9 a.m. every morning and give someone their medication. It's not always the way it works. So there's a bit of nuance there.
There's a lot of nuances. Thank you. Thanks.
Okay.
Appreciate it.
I would just also, I see your question, Rachel. I'll just, before we hit 12 o'clock, I'll just let everyone know that we are offering 10% off our medication package. So we'll send this out in an email with all this, 10% off the medication package. And on our LMS, we've got assist clients with medication. It's based on the RTO course. It's usually $45 a person, but you'll be able to get it for $20 per person. We'll send all the details out about that in the email after this session. So Rachel, if a support worker is providing community access in-home, should they still be following the same processes too? So when the support worker goes into the home, should they be signing med charts following administration? So the question that it would be is if you are having to check that someone's taking the medication, if you're having to remind them in their own home to do that, or if you're having to give it to them physically or actually administer it, then yes, you're doing medication management. If none of that is required, then it's not medication management. You don't have to be worried about it. So if you were going into their home and checking that they've done if they've taken their medication, then you would be signing a record because you'd be saying, yes, I saw them take it, or no, they didn't take it today, or I didn't see them take it.
Yeah, and I think it comes back to medication capacity assessment. Okay, so that's why it's so important to have conducted. There are people on the edge of being able to take their own meds and not being able to take their own meds. And if they can take their own meds, like functionally, neurologically, they're able, then we don't need to mollycoddle them. So medication, functional assistant, bring it back to a data, bring it back to the data. Use a medication capacity assessment. You might find you're supporting people who actually don't need it. Yeah.
Yes.
And yeah, go ahead.
Oh, sorry, I was just going to ask if there was any more questions.
Yeah, on the same note, does it have to be stated in the service agreement? Do we kind of outline that the medication is going to be administered
You'd need
or not?
consent somewhere. So
Consent, yeah.
usually we have that in a comprehensive assessment or support plan. It'd be outlining the supports that you're giving. So you would be listing there. That's another common issue we see is that people tick there, no, I don't want any medication assistance. And then it turns out that the staff are actually reminding them. So making sure as well, checking that paperwork too, to make sure that you haven't said, so someone hasn't said, no, I don't want medication assistance, but then is asking to be reminded because that is, so you need
Yeah.
to make sure that that's all taken care of.
Yeah, it's an educational process, making sure other people understand that process, and for that you'll need to understand it fully yourself.
Yeah, definitely.
Well, what if we want to book for all our staff just to cover how much? So do you mean with a competency or our LMS? Because our LMS, it's $20 per person if you wanted to do that. If you wanted to get a competency from an RTO, you'd need to find an RTO and get a quote from them. It'll depend on the place.
What's ref?
I think it might mean RTO.
Okay, well, we can't help you with that because we're not an RTO.
So you'll have to check with the local
Plenty of
ones
them out
around.
there though.
Yes, you'll have to check with them to see how much it would cost to get all your staff trained. Otherwise, you can get, like Gina was explaining before, you can get your like the managers to do the training and then check the competency of everyone else. Um, if there's anyone got a final question, otherwise we can wrap it up here today. And we'll send out this recording and all of that special information as well.
Thank you, everyone. Thank you, Ali.
No problem. Sorry,
Thank you.
I think my camera stuffed up a bit there. It turned off, but I
Never
think we're all
mind.
good. Thank you, everyone.
Thank you.
I'm glad you enjoyed.
Hi, sorry,
Hi.
just a question.
Yep.
As an RN, can I complete the competency with my staff
Yes,
medication?
but they've still got to have theory.
Yeah, okay. So
Yeah.
they have to complete the modules with
Yeah, they
Samia
have to
and
have some theory. Yeah.
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 okay, yeah.
But you can do the
But the
competency,
regular,
yes.
yeah, I think did you say every 3 monthly we have to do the competency? I missed some
No,
part
no,
in the
no, no.
beginning.
If someone hasn't touched any medication management, and that's unlikely for most staff in 3 months, then they should have it revisited. But
Okay,
but
yeah,
but after that, it should be just annually.
annually. Okay,
Yeah. Yeah.
thank you.
Okay.
Thanks, everyone.
Thank you so much.
Thank you.
Thank you.